Assalamu alaikum. In this part 2 lecture on vocal fold lesions, we'll discuss some uncommon vocal fold lesions, including things like vocal fold pseudocysts, sulcus vocalis, mucosal bridges, abnormal blood vessels, and vocal fold acute haemorrhage. The vocal fold pseudocysts are benign, fluid-filled lesions that occurs just beneath the epithelial surface of the vocal folds in the superficial part of the lamina propria, the so-called rhinix space. Unlike true vocal fold cysts, they lack an epithelial lining to the fluid-filled space. They appear like a localized rhinix edema, localized in only one part of the vocal fold, usually at the mid-membranous level. Its presence may indicate an underlying disturbance in the glottic closure mechanism. It is usually associated with this defective vocal fold closure. The cyst is filled with serous fluid, and in that aspect it differs from a true cyst and from polyps. The average age of the patients is somewhere between 29 and 30 years. More than 3/4 of the patients are vocal performers, and about 87% were females. In the case of the much rarer bilateral pseudocysts, these occurs almost exclusively in females. Kaufman defined the pseudocysts as discrete and unilateral localized areas of rhinix edema. In a study by Kaufman and Bilafiski, they showed that this fluid-filled lesions looks like a blister in the mid part of the membranous vocal folds, and showed that it is usually associated with a defective vocal fold closure at this area. In fact, they raise the awareness that if pseudocysts are found, then a thorough examination should be carried out to exclude any defective vocal fold movement or paresis. They called this the paresis podule. It looks like a mixture between a nodule and a polyp. That's why it's called podule, and they relate it to a paretic vocal fold or other causes of glottic insufficiency. And pathology of any excised lesions would show the characteristic feature of lack of epithelial lining. This is key diagnostic feature, together with serous or mucus fluid collection in the lamina propria underneath an intact epithelium cover of the vocal fold. The wall shows reactive connective tissue with fibrosis and edema, and also capillary proliferation and mild chronic inflammatory infiltrate in areas of previous hemorrhage or capillary leak. These pathological features would explain the voice changes associated with the vocal fold pseudocysts. There will be increased amount of scarring and fibrosis that results in a deficient superficial part of the lamina propria that on its turn will result in vocal fold stiffness, localized vocal fold stiffness in this area. In addition, there will be changes associated with new vascular formation, resulting in blood vessels formation being perpendicular rather than parallel to the vocal fold edges as shown in narrowband imaging. The pseudocysts would also be responsible about changes on the contralateral vocal fold epithelium, which would show some reactive thickening. So there will be vocal fold localized stiffness on the ipsilateral vocal fold and some reactive changes on the contralateral vocal fold, together with these telltale perpendicular blood vessels. In the early stages of the pseudocyst formation, the patient may remain asymptomatic. Soon enough, there will be some voice changes in the form of dysphonia and a breathy voice that reflects the glottic closure insufficiency. together with symptoms of voice fatigue because of the need to increase the subglottic pressure and loss of the vocal fold frequency range, particularly at the higher frequencies, particularly in singers, and occasionally voice strain and discomfort. Laryngeal examination would show a usually unilateral fluid-filled lesion on the edge of the vocal fold that is localized and subepithelial and non-vibrating. It would also show the presence of ectatic blood vessels perpendicular to the edge of the vocal fold. These findings are not very specific and they can be shared by things like a true vocal fold, cyst, or even a sulcus vocalis, and sometimes even stroboscopy could not differentiate between a true cyst or a pseudocyst. In these cases, if laryngoscopy suggests these features, the surgical exploration will give the definitive diagnosis. We move now to the management, starting with the first line in the management, conservative treatment, aiming at reducing the inflammation of the vocal folds and restoration of the normal vibratory functions and the voice quality. The way forward will be modification of the vocal behavior and techniques by a speech and language pathologist and therapist, and helped by vocal rest and hydration. Voice therapy and conservative management should be tried for at least 6 to 12 weeks and should be continued if there is any signs of improvement. But if there is no improvement at all with persistent voice symptoms after 12 weeks, then this is one of the indications to consider surgical intervention. The other indications are in professional voice users who require faster or more complete recovery, and in large or non-resolving pseudocysts that cause a significant disruption of the mucosal wave that is unlikely to settle with voice therapy alone, or when there is diagnostic uncertainty, especially to rule out a true vocal fold cyst that is not expected to resolve with voice therapy. The creation of a vocal fold lateral microflap is facilitated by injection in the rhinic space of saline and diluted adrenaline, and then a lateral chordotomy is carried out either by cold steel or by carbon dioxide laser between the lateral part of the pseudocyst and the position of the vocal fold ligament, followed by evacuation of the fluid-filled space together with any associated scar tissue or pseudocapsule. And this then is followed by repositioning of the microflap back to cover the vocal ligament. 2 more points. Sometimes after the end of the operation, the vocal fold edge will be defective at this area of the resection or notched, and in this condition you may consider either injection, laryngoplasty, or subsequent augmentation, laryngoplasty. The other point is that sometimes pseudocysts would have an opening to the surface of the vocal fold, and if that's the case, this should be excised together with the resected fluid-filled space and the associated scarring around it. We move next to vocal fold sulcus, Sulcus vocalis. These linear furrows in the epithelial cover of the vocal folds can have variable depth. They can reach as far as the vocal ligament and beyond to the thyroarytenoid muscle, or they can be superficial with only a small dip into the superficial layer of the lamina propria. They were first reported by an anatomist, which is not surprising given that the incidence of sulcus vocalis in cadaveric larynxes could reach as high as 20%. Only very few percentage of them would be symptomatic and would present to an ENT surgeon or a laryngologist. It's considered one of the most difficult lesions to diagnose and treat in the vocal folds pathology. They cause glottal dysfunction with impaired glottal closure, a breathy component to the voice, and consequently vocal fatigue and athenia. They also stiffens the vocal folds, and the mucosal waves would be disordered, and the voice would have a higher pitch and would be perceived as rough and breathy. A widely accepted classification of the sulcus vocalis was proposed by Ford in 1996. It's based on the depth of the invagination of the epithelial cover into the vocal fold substance. It's useful because it correlates well with the severity of the patient's symptoms, and also correlates well with the type of prognosis after treatment. These are coronal sections in the vocal fold substance, showing the body, the core of the vocal fold formed by the vocalis part of the thyroarytenoid muscle, and the vocal ligament formed by the deep and the intermediate parts of the lamina propria, and the superficial part of the lamina propria in pink. And type 1 is just a small depression of the epithelial cover into the superficial part of the lamina propria, the rhinx space. In type 2, it invades further into the substance of the vocal ligament, and in type 3, it penetrates the vocal ligament and reaches the vocalis muscle as well. The type 1 sulcus vocalis is termed a physiological sulcus. It is just a minor dip of the epithelial cover into the rhinx space, the superficial part of the lamina propria. It does not reach the vocal ligament and does not cause much of a voice disturbance. Stroboscopy would only show mild mucosal wave abnormalities, and the treatment could be conservative in the form of speech therapy. Type 2 sulcus vocalis is sometimes called type 2A or sulcus vergeture. The basic problem here is a defect in the superficial part of the lamina propria, either failure to develop congenitally or atrophy of the superficial part due to repeated phonotrauma, injuries to the vocal fold, or even inflammatory processes. This will cause the epithelial cover to reach the vocal ligament, and this is going to cause disturbance to the mucosal wave and affect the voice. Stroboscopy would show moderate mucosal abnormalities, and the voice would also be affected, being a bit breathy and also rough. Type 3 sulcus vocalis is sometimes termed type 2B or a classic sulcus vocalis. This is the most deep of the three types of sulcus vocalis. There is a focal pit that extends through the superficial part of the lamina propria, the vocal ligament, to reach the thyroarytenoid muscle itself. And this is going to cause a marked disturbance of the mucosal wave. There will be a significant mucosal wave abnormality on stroboscopy, and would also, the phonatory gap would now reach more than 3 millimeters. This would result in a breathy and a rough voice that is occasionally high-pitched because of the stiffness of the vocal folds. And this will also be associated with voice fatigue and effortful phonation that are common complaints for this deepest type of sulcus vocalis. Some authors suggest the theory that vocal fold sulci are just opened up epidermoid cysts. Epidermoid cysts can form either due to congenital remnants or acquired after phonotrauma or inflammatory processes. They argue that if the cyst opens up superiorly and discharges some of its contents, the neck of the cyst and its body remains embedded in the vocal fold substance and form a sulcus vocalis. This is based on the very high association between sulci and the epidermoid cysts. Up to 15% of patients with sulci would also have epidermoid cysts in one large series. Is there any relationship between the development of vocal fold sulci and other benign vocal fold lesions? This was investigated in a very large series from Italy of more than 230 patients with benign vocal fold lesions. In about a third of the patients, vocal fold sulci could be identified and associated with other benign vocal fold lesions like vocal fold polyps or nodules or rhinx edema. The study could not establish whether there is a cause and effect relationship between the vocal fold sulci or the benign vocal fold lesions, who came first and caused the other, or indeed if there is a common etiology for both, like phonotrauma or degenerative conditions following inflammations or other types of injuries to the vocal folds. On stroboscopy, the features described by Hirano are medial bowing of the vocal fold edges, and if the sulcus is bilateral, the phonatory gap would be spindle-shaped. The mucosal wave would have a reduced amplitude, and there would be irregularities in the mucosal wave, particularly in the area of the sulcus itself. These features are not diagnostic of vocal fold sulcus because they can also be seen in conditions like vocal fold scarring or vocal fold atrophic changes. Dysphonia in the case of sulcus vocalis patients are caused by the glottic insufficiency due to the bowing of the vocal fold edges and the stiffness of the vocal folds due to the presence of the sulcus and the degree of its penetration into the vocal fold itself. This would cause stiffness of the vocal folds and a reduced mucosal wave, small in the vibratory amplitude. On acoustic analysis, the fundamental frequency would be higher due to the vocal fold stiffness. Jitter and shimmer would also increase, and the harmonic to noise ratio will be reduced due to the increased amount of noise in the signal. The aerodynamic studies would show expectedly the reduced maximal phonation time due to air leak, and the mean air flow and the subglottic pressure together with the phonation threshold pressure would all be increased. The management of sulcus vocalis cases should have two aims. The first is to restore the mucosal wave that has been disrupted by the presence of the sulcus, and the other is closing up of the phonatory gap caused by the medial edge bowing in the case of sulci. A trial of voice therapy is the usual starting point, particularly in mild cases like type 1 sulci. This may be all that is required, and the voice would improve and can be satisfactory to the patient and will also avoid all the hazards of the surgical intervention. But many cases, particularly type 2 and type 3 cases, would require surgery that should be very precise in order to remove all the sulcus remnants, which is not an easy job, and should also be very conservative in order to reduce the amount of post-operative scarring and reduce the amount of resection of the mucosal cover of the vocal cords that can lead to further stiffening of the vocal folds. The post-operative voice therapy is essential and can extend up to 9 months. Other consideration would be the correction of the phonatory gap post-operative or intraoperative by medialization procedures of the vocal fold like thyroplasty, or augmentation of the vocal folds by injection or by implantation of fat and similar materials. The oldest and the commonest procedure is excision of the sulcus vocalis and reapproximation of the epithelial edges. It starts with subepithelial infiltration with adrenaline mixture with saline, and this would help in delineating the sulcus and also would cause lifting of the sulcus of the surrounding tissue by hydrodissection, followed by chordotomies, elliptical incision around the orifice of the sulcus, better made with lasers. This is then followed by very meticulous subepithelial dissection of the sulcus, particularly of the vocal ligament and beyond. The aim is to cause the least amount of scar tissue, particularly around the vocal ligament, and to remove the least amount of the epithelial cover, because this could lead excessive removal, and excessive scarring could lead to further vocal fold stiffening. Once the sulcus is removed, the gutter between the vocal ligament and the epithelial edge could be obliterated by approximation of the two epithelial edges and suturing them with either 5 or 6O absorbable material or by the use of glue. A different surgical approach in the management of sulcus vocalis patients is vocal folds medialization, whether or not the vocal fold sulcus itself is excised. This should be considered in cases of a phonatory gap more than 1.5 millimeter. The procedure can be combined with injection of fat, lipo-injection, in the subepithelial space in an attempt to re-establish the mucosal wave. This approach is useful in bilateral sulcus vergeture, in which the dissection itself is very difficult and can cause more damage by inducing excessive scar tissue. Avoiding the resection of the vergeture and medializing the vocal folds together with lipo-injection could give satisfactory results. The third uncommon vocal fold condition that we shall go through now is vocal fold mucosal bridge. A vocal fold mucosal bridge is an epithelial strip that lies free over the vocal fold epithelium. It's attached only anteriorly and posteriorly, otherwise it's free and you can pass a blunt probe underneath it. It's like a band of mucosa that is longitudinally placed, usually parallel to the vocal fold edge. Histologically, the free mucosal bridge is formed of a core of connective tissue formed by the outer layer of the lamina propria, the rhynchus space. This is circumferentially covered by the stratified squamous epithelium. The vocal fold itself is also covered by stratified squamous epithelium that is almost always attached to the vocal ligament, the intermediate and the deep layers of the lamina propria. Resection of the mucosal bridge to correct the abnormality is not going to correct the dysphonia, as this would leave the indentation in the vocal fold and the glottal insufficiency, plus the stiffness of the vocal fold cover that is now attached directly to the vocal ligament. How can a mucosal bridge of the vocal fold develop? According to the congenital etiology theory, if a sulcus vocalis or an epidermoid cyst of the vocal fold has double punctures, then a small area of the isolated epithelium would lie free over between the superior and the inferior puncture and form a mucosal bridge. The other theory of the acquired origin, the mucosal bridge would develop because of injuries, microtrauma to the mucosal cover of the vocal fold, because of misuse or abuse, or because of inflammation, and that would leave us an island of mucosal cover epithelium over the surface of the vocal fold true cover. Mucosal bridges and the other member of the group of minor structural alterations of the epithelial cover are very difficult to diagnose, except perhaps under anesthesia with microlaryngoscopy and palpation of the vocal fold surface. But one way of suspecting the presence of this type of lesion is to look into the pattern of the superficial blood vessels over the vocal fold surfaces. If a patient has a mucosal bridge or a vocal fold sulcus, for example, then in about 90% of the cases there would be an abnormal pattern of blood vessels of the vocal folds. This is much higher than the control group, which have abnormalities in the blood vessels in about less than a third of the patients, or even with polyps or nodules. One characteristic form of these abnormalities is the tangled blood vessel with frequent change of direction, and this is almost pathognomonic of a vocal fold sulcus or a vocal fold mucosal bridge. Other forms of abnormalities would be when a blood vessel is running transversely rather than longitudinally, or when there is an abrupt change in the caliber of the blood vessel, either abrupt narrowing or abrupt dilatation, forming an ectasia and dilatation of the blood vessel. The dysphonia in the patients with mucosal bridges would be caused by impairment of the vocal fold mucosal vibration, the interruption in the mucosal wave. This would lead to voice fatigue and a voice that deteriorates rapidly. They would have higher pitches, they would have higher fundamental frequencies, and the voice would have a rough and a breathy component. The breathy component is due to the glottic insufficiency caused by the mucosal bridge. There will also be frequent fluctuations in the voice, frequent perturbations in fundamental frequency and the vocal intensity. Examination of the larynxes of patients with mucosal bridges may not show the lesion at all. Either the use of flexible laryngoscopy or direct laryngoscopy may not show the lesion. It may show an abnormal blood vessel pattern that would suggest the presence of a lesion. Stroboscopy could also suggest the presence of the lesion if there is a sudden reduction in the vibratory pattern over one area. The stiffness of this area would suggest either a vocal fold sulcus or a mucosal bridge, and only direct microlaryngoscopy under anesthesia with palpation could tell the difference between a mucosal bridge and a vocal fold sulcus. The management of vocal fold mucosal bridges should focus on two things: restoration of the vocal fold mucosal wave and closing the glottal gap caused by the glottic insufficiency. A trial of voice therapy is always a good start, particularly when the symptoms are mild, but many patients will require surgery that has to be very precise in order to avoid any excessive mucosal resection or any excessive postoperative scarring or any injury to the vocal ligament. And postoperative voice therapy in all cases would be mandatory. The second focus is the glottic gap, and this can be sorted out after resection of the mucosal bridge by either fat injection or fat implantation, or using collagen rather than fat, or medialization procedures like type 1 thyroplasty. If surgery is indicated, microlaryngoscopy under anesthesia would be the best choice to resect only the undersurface of the mucosal bridge, not the whole of the mucosal bridge, just the epithelial cover of the undersurface of the mucosal bridge. Exposure of the bridge area can be improved by averting the medial edge of the vocal fold. Gentle pressure on a pledge placed laterally on the superior surface of the vocal fold would help in this aversion. And once a good exposure is achieved, the mucosal bridge is incised and only the undersurface epithelium is removed carefully, leaving the outer surface epithelium and the core of the connective tissue in sight, followed by removal of the epithelium overlying the vocal ligament of the vocal fold carefully so as not to injure the vocal fold ligament itself and not to cause any excessive scarring in the area. Once the two epithelial surfaces, the opposing surfaces, are removed, the remnant of the mucosal bridge with the outer cover and the core of the connective tissue are then draped over the vocal fold or glued in place in order to help in restoring the mucosal wave. After this, consideration should be given to any procedure necessary to close any glottic gap by fat injection or implantation or type 1 thyroplasty. The use of pulsed dye laser fibers can greatly improve the precision of the surgical intervention. The laser fibers are used to remove the epithelium from the undersurface of the mucosal bridge and the corresponding area of the vocal fold. And once the raw surfaces on the two sides are clear from any epithelial remnants without any injury to the vocal ligament itself, then the mucosal bridge remnant formed by the outer layer of the mucosal bridge and the core of the connective tissue can be draped or glued to its original site on the vocal fold. As you can see, the preoperative glottic gap has now disappeared after surgery and the mucosal wave was restored. And next, we shall discuss the vocal fold's abnormal vascular patterns. The blood vessels on the surface of the vocal folds in the lamina propria approaches the center of the vocal fold from anterior and from posterior. The middle part has less diameter of vessels than the anterior and the posterior part. These vessels would run parallel to the vocal fold edges in the healthy subjects. You can see this clearly in the narrowband imaging, which shows the blood vessels much more clearer than the white light. This arrangement of parallel blood vessels to the edge of the vocal fold protects the blood vessels from the shearing effect of high-frequency phonation. This can produce various disorders in blood vessels if they are running perpendicular rather than parallel to the vocal fold edges. Also, you can see that the vocal folds are a little bit tortuous, and this is to allow for stretching of the blood vessels when the vocal fold changes its length during phonation, producing high frequencies, for example. These two features, the parallel arrangement and the tortuosity of the blood vessels, optimizes the mucosal wave of the vocal fold, providing flexibility during shearing effects during phonation. The microcirculation of the capillaries in the superficial part of the lamina propria is also well adapted to withstand stress. The vessels that course in the longitudinal direction parallel to the vocal fold edge also don't anastomose with vessels coming out from the deeper layer of the vocal folds. And these vessels, the endothelial cells, are surrounded by a cushion of extensive concentric lamella from the basement membrane, and also they are reinforced with some filaments, intracellular filaments, to protect against high mechanical vessel wall stress. Even then, the phonatory vibration can produce sometimes forces sufficient to tear these fragile capillaries, resulting in bleeding within the superficial layer of the lamina propria. And of course, if there are abnormal blood vessels on the surface of the vocal folds, like a varix or an abnormally dilated blood vessel, this can make these segments of blood vessels more vulnerable to rupture and produce a hemorrhage. The abnormal blood vessels on the vocal fold can take different shapes. The original description and classification by Hockmans described three of these. The first is the varix. This is a dilated, a prominent, and tortuous blood vessel, like a varicose vein. This is the varix, and you can see it in here as well. The second is the ectatic blood vessel. Ectasia refers to a coalescent hemangiomatous appearance, like in here. And the third group is the spider telangiectasia, which describes a delicate network of superficial blood vessels on the surface of the vocal fold, usually associated with some systemic disease. And then other forms of abnormalities were added, including the convoluted vessels of the vocal fold, which describes an advanced stage of the varix with a very prominent, organized, and deformed blood vessel on the surface of the vocal fold. The etiology for abnormal blood vessels of the vocal folds, top of the list is phonotrauma. The mechanical stress leads to microvascular injury, and this can result in capillary wall weakening and dilation, and possibly microhemorrhage as well. Inflammatory condition of the vocal folds, including of course laryngopharyngeal reflux, can alter the vascular permeability and leads to ectasia. Certain hormonal factors, including estrogen, can influence the vascular fragility and permeability, and this explains the increased incidence in females before menopause. And also age-related factors can relate to vessel fragility and genetics, and some are predisposed towards some vascular malformation, particularly the telangiectasia. This is now recognized, the fifth group, the neoplastic neoangiogenesis. These are the new blood vessels formation related to the development of malignant or pre-malignant conditions of the vocal folds. The pathology associated with the longitudinal vascular abnormalities would show dilated capillaries and venules in the lamina propria, sometimes associated with certain amount of fibrosis and hemosiderin-laden macrophages, particularly after a previous hemorrhage. But there may be also signs of epithelial hyperplasia or inflammation. In the perpendicular blood vessels abnormalities, there would be some changes in the epithelium. These whitish patches may actually obscure the vascular markings, the so-called umbrella effect. They just cover these vascular markings, and the pathology would show the dysplastic epithelium together with the papillary loops arrangement. In general, the vascular lesions are more common in females before the menopause, and they are frequently seen in patients who have high vocal demands, particularly professional singers or voice users. They sometimes can present with recurrent vocal fold hemorrhage as well, plus their lesions. Most of these lesions would present on the superior surface of the vocal fold, almost 77%, and some of them would present on the edge of the vocal fold. And most of the lesions would be in the middle third of the membranous vocal fold, which is the area of the greatest aerodynamically induced shearing stress during phonation. How do these vascular lesions present? If the lesions are early or small on the superior surface of the vocal fold, they may remain asymptomatic or have very subtle symptoms because they don't cause intrinsic stiffness or mass loading effect on the vocal folds. But if they happen to be on the medial vibratory edge of the vocal fold, they can start to cause dysphonia due to the mass loading effect or disruption of the mucosal wave. So dysphonia can be the initial symptom, together with voice fatigue and intermittent voice loss. There would also be an effortful phonation and loss of easy onset phonation as well. In professional voice users, the symptoms may be a bit different. They can describe a decreased vocal range or difficulty in gliding the voice into the high soft notes. They can describe higher phonatory threshold pressure necessary to produce the proper sound, and this higher pressure would actually cause a vicious circle because it would lead to more trauma and injury to the microcirculation, causing further disruption and microvascular injury. Sometimes they can present with severe sudden dysphonia resulting from acute subepithelial hemorrhage. The examination will show the different forms of the vascular lesions and would be helpful in taking the therapeutic decisions. Here, for example, you see a small ectasia that becomes more prominent during singing, and this may require a laser. Here you could see a more prominent varix and some ectasia on the other side, and this becomes much more prominent during the menstrual cycle and can be treated by hormones therapy. Here you could see multiple branching of the blood vessels, multiple dilated, but without formation of the varix, and these can be treated with voice therapy and voice hygiene. Here you could see vessels going away from a central point in both directions with various branching. These would usually be associated with a lesion somewhere here. It can be a small sulcus vocalis or a mucosal bridge that requires examination under anesthesia, or you can see a small vascular polyp in here that requires not only excision but also lasing of the feeding vessel. And the evaluation can be carried out with the usual flexible or rigid laryngoscopy using the white light that can visualize the vascular lesion if it is very evident, or better still, you can use the high definition laryngoscopy with the narrow band imaging. Here you use only filtered light to visualize the mucosal and the submucosal microvascular arrangement. As you can see it more clearly here compared to the white light image. Stroboscopy can be helpful to show a disruption of the mucosal wave in cases of associated pathology like a vascular polyp, or sometimes the mass loading effect of lesions on the medial border of the vocal fold. The main risk factor for hemorrhage in the vocal fold is having a varicosity in the superficial layer of the lamina propria. If a patient has a varix, then he is 10 times more likely to have a hemorrhage than those who don't have a varix. This was shown by the hazard regression analysis. But although the rate of hemorrhage is significantly higher in patients with varix, the overall incidence is still quite low. And now to the management decisions, particularly for the longitudinal arrangement. These are usually reversible, and you can start the treatment conservatively with voice therapy, particularly for the professional voice users, together with voice hygiene. Some medical treatment can sometimes be needed to control laryngopharyngeal reflux, or with estrogen progesterone modulation if the symptoms are linked to menstrual cycles, for example. If surgery is indicated, then 3 different approaches can be discussed. The first is just a cordotomy to evacuate a subepithelial hemorrhage. The second is a microflap resection of a vascular lesion. And the third is the use of laser, whether it is carbon dioxide, this is the oldest version, or the pulsed laser or KTP to coagulate or vaporize the abnormal blood vessels. The patients who would benefit from surgery are the patients who present with recurrent hemorrhages in the subepithelial part of the vocal fold, or if the patient has an associated mass lesion like a polyp, a vascular polyp in the vocal fold, or describes a voice limiting symptoms, or has the lesion on or nearby the medial edge of the vocal fold, the vibratory margin that may interfere with the vibration or the glottic closure, or when the symptoms of dysphonia or voice fatigue is caused by a vascular lesion that engorges during heavy voice use, like long singing, or of course if there is any suspicion of a sinister underlying pathology in perpendicular blood vessels, and to evacuate a hematoma in case of acute subepithelial hemorrhage that does not settle conservatively. On the other hand, the patients who may not benefit from surgery, and so there is no strong indication for surgery, are the patients who are asymptomatic and their lesions does not look like there is a significant risk of hemorrhage, or in patients who have vascular abnormalities that is related only to the menstrual cycle, because these can be treated by hormone therapy, or in patients who have telangiectasia associated with Osler-Weber's Rendo syndrome, or in professional singers, particularly the high sopranos, who have minimal symptoms because of the increased risk of adverse effects on their performance that can be associated even with minimal post-operative stiffness. This can outweigh any benefit of surgery. Operative resection would entail a good exposure to the vocal folds, and once the lesion is identified, a mini flap can be raised by incising just lateral to the vocal fold abnormality, just lateral to it. You have 2 or 3 millimeters in length, a micro flap would be raised, followed by using of a hook or a fine needle to dissect the vascular abnormality from the lamina propria and resecting the lesion with minimal loss of the epithelium and minimum disruption to the lamina propria. But laser therapy is now the preferred treatment modality, again through a microlaryngoscopy approach. Carbon dioxide laser was initially used in the defocused mode with brief pulsing mode and low power setting, 1 to 2 watts. And this is used to coagulate an offending vessel like a varix or an ectasia at 2 or 3 different spots along its length. This may be now superseded by photoangiolytic lasers like the pulse dye laser or the KTP. They can be sometimes used in an outpatient setting, and they are used to obliterate the vessels without surgical intervention, targeting the hemoglobin in the vessels tissues, and this is usually quite effective. The KTP 532 laser can be used for photocoagulation of small vascular lesions because the laser beam will be very well absorbed by the hemoglobin and the damage to the epithelium is minimum. It can be used in a low power setting of 1 to 2 watts in a continuous mode with 0.4 to 0.6 millimeter beam for 3 to 7 seconds, delivering a total of 3 to 7 joules. It's not recommended to use the KTP for things like a hemorrhagic polyp or a hematoma after a subepithelial vocal fold hemorrhage, because these lesions would require a higher doses and can cause more scarring because there is little blood flow inside, and the photocoagulation is either impossible or requires too much laser energy. These lesions, the vascular polyps or the subepithelial hematoma, are better treated by open surgery resection. But the KTP laser is cost effective and time saving and can provide excellent results compared with other modalities. Next, we shall discuss the vocal folds acute haemorrhage. The acute hemorrhage is caused by ruptures of capillaries that travel through the superficial layer of the lamina propria of the vocal fold. The inciting factor is typically phonotrauma, but can also be caused by mechanical stress such as coughing, for example. The blood would then diffuse through the superficial layer of the lamina propria, which has very low resistance to the diffusion of the fluid, and this would increase the vocal fold mass and also the stiffness because of the different properties of the escaping blood from the fluid in the lamina propria. The combined effect of increasing mass and stiffness would alter the pattern of vocal fold vibration and cause sudden dysphonia. The appearance is striking and can cause significant concern to professional voice users. The etiology and the risk factors. Phonotrauma comes as number 1 of the list, usually during singing or high demand performance like teaching or voice abuse or coughing, and also medications including anticoagulants and non-steroidal anti-inflammatory drugs, and some systemic conditions like bleeding disorders. A positive correlation has been established between the hemorrhage and the use of anticoagulants or a recent upper respiratory tract infection or acute vocal trauma during a performance. Other factors such as recent surgery, smoking, and even hormonal changes in females, although this is only based on observational studies. Predisposing factors include viral illness, laryngitis, including laryngopharyngeal reflux, and pre-existing vascular ectasia or during menstrual cycle. The common clinical presentation is sudden voice loss, usually with certain amount of voice roughness. Almost all patients would present with this. He also described voice fatigue and throat clearing. A good percentage of the patients would have a concomitant lesion. Almost 3/4 would have a concomitant lesion in the vocal folds, ranging from benign mucosal lesions to things like either a mucosal bridge or a sulcus vocalis. The most common of these lesions would be a hemorrhagic polyp, and about 1/3 of the patient would have a varices, a varicosity, usually on the same site of the bleeding. The performer, the voice performer, particularly singers, would usually know exactly the point at which they have lost their voice and would know how to request urgent consultation for this. If they stop using their voice at the initial stage, they may have a bleed under the surface of the epithelium in the superficial layer of the lamina propria. But if they continue despite feeling the sudden loss, if they still give the effort to phonate, they may end up with a large hematoma in the vocal fold. But the main value of stroboscopy in cases of acute vocal fold hemorrhage is to differentiate between two types of patients. The milder type would be just a blush of red hue under the surface of the vocal fold due to capillary leak. And the other type is a hematoma that can be extensive due to collection of blood in the lamina propria. In the milder type, this can be expected to resolve quickly with some voice rest, relative voice rest, which would mean abstinence from loud and prolonged speaking. Whereas if there is a mass loading and hematoma formation, then the patient would require strict voice rest, absolute voice rest, so as not to extend the size of the hematoma, and it would usually take much longer to resolve than the milder. The management of acute vocal fold hemorrhage is essentially conservative, apart from few indications for surgical intervention for selected cases. The main line of treatment is voice rest for at least a week that can be extended further if needed. This is particularly important for professional voice users and patients who also have an associated mucosal pathology in their vocal folds, together with vocal hygiene education. Medical treatment is essentially reflux management if indicated, and to stop the use of anticoagulant medication if that is possible, and avoid non-steroidal anti-inflammatory drugs. And in certain patients, an oral steroid course can be used with precautions, but this is not universally accepted, and good hydration. Surgical intervention would be considered in few cases, few selected cases. This would include those patients with massive subepithelial hematoma. In these cases, you may consider doing a lateral chordotomy and evacuation of the hematoma, or patients who have a varix or other vascular lesions of the vocal folds in whom photoangiolytic lasers, coagulation or vaporization may be considered, or if the vascular lesion on the vocal fold is at the vibrating margin or the undersurface, you may consider doing a microsurgery and microflap with resection of the offending vessel. The indications for surgical intervention in selected cases of acute vocal fold hemorrhage include patients who have recurrence of the hemorrhage more than a single episode, or a single episode of hemorrhage if the patient have a varix or other abnormal blood vessel on the vocal fold, or if he has a hemorrhage and an associated mass such as a cyst or a polyp that require microsurgery, or in the very rare cases where evacuation of an extensive vocal fold hematoma is required. It is interesting to note the results of a survey conducted on the members of the American Association of Broncho-Esophageal Association. They showed that the members would usually intervene surgically on a vocal fold with a varix or an ectatic vessel following a single episode in about 33% of the cases, but about 55% of them would require 2 episodes of hemorrhage plus the varix in order to indicate surgery. They use angiolytic lasers like KTP, mostly in the operating room, but also in an office setting. And they have noted that their cases of vocal fold hemorrhage sometimes evolve to become a vocal fold scar in a small percentage of the cases, less than 10%, or it may form a hemorrhagic polyp in about 18% of the cases. The members of the American Association recommend the use of a stroboscope to guide the decision to get back to gradual voice use based on the stroboscopic evidence of resorption of the subepithelial blood and the return of the normal mucosal pliability. The angiolytic lasers are the preferred surgical intervention technique for most cases of abnormal blood vessels of the vocal fold, including varices or ectasia, particularly if the abnormal blood vessels are on the surface of the superior part of the vocal fold. But when the abnormal varices or ectasia are actually on the margin, the vibrating margin of the vocal fold, it's preferable to use microlapharyngosurgery resection of the offending vessel to avoid any collateral damage to the vibrating margin of the vocal fold, together with stiffness. Surgical intervention, again in the form of resection of the offending vessel, may also be considered if the offending vessel may leave around a mass-like structure even after the use of laser ablation. And finally, we shall go through the potentially sinister transverse vocal folds vascular patterns. Abnormal blood vessels on the surface of the vocal folds can originate from 2 different pathologies. One is entirely benign. These are the longitudinal vessels running parallel to the free edge of the vocal fold and triggered by mechanical stresses like phonotrauma, and these vascular changes can be reversible. The other, the transverse or the perpendicular blood vessels, can be either benign or they may carry the risk of being premalignant or malignant lesions running perpendicular to the free edge of the vocal fold as an indicator or feeding vessels. Another abnormality in the vascular system of the vocal folds is the indicator or the feeding vessel. These vessels form from branching of vessels closer to the ventricular side of the vocal fold surface. They turn perpendicular to the surface and try to reach the lesion. They are seen more clearly on the narrow band here. They arise from the lateral part and passes perpendicular to the edge of the vocal fold to reach the lesion in here. These are indicator or feeding vessels. They don't only form with sinister pathologies like malignant or premalignant, they can also form with polyps or cysts. So they can indicate a lesion that can be either benign or a tumor. and it just points to something wrong happening. Sometimes it can even be scar tissue. That's why it's called an indicator vessel. A certain growth factor called the vascular endothelial growth factor, VEGF, is strongly associated with new vessel formation associated with tumors or pre-malignant lesions. This vascular endothelial growth factor is produced in response to several things. Some of them, like oncogenes or inflammatory responses or cytokines or even tissue hypoxia, are associated with tumor formation. It belongs to the family of platelet-derived growth factors that allows the new vessel formation, endothelial growth that allows new vessel formation, and also stimulates its connection to the new cells formed by the tumor. This new vascular or microvascular lesion is the prime reason for the reddish hue of the vocal fold in cases of pre-malignant or sometimes the established malignancy. The top of these loops can be seen as dots over the vocal fold, and the reddish appearance reflects the increased density of subepithelial vascular structures. So when there is a process of malignant transformation associated with oncogenes and hypoxia, the produced vascular endothelial growth factor will stimulate the growth of new vessels from capillaries of the host towards the anoxic area in the new malignant transformation lesion. These new blood vessels would have very fine extensions, very fine tubes like called filopodia that would ultimately fuse with corresponding filopodia from the tip of the tumor cells to establish a new microcirculation, giving blood flow to the newly formed tumor cells, and this would allow the tumor to progress. This new vascularization on the surface of the vocal folds is presented with increased density of subepithelial vascular structures, secondary to the process of neoangiogenesis. They form what is termed as intraepithelial capillary loops, IPCL. These are blood vessels loops in the interpapillary parts of the surface epithelium. These are the hallmark of tumor growth, invasion or metastasis, and represent an early step in the malignant transformation process. Classification of the morphology of these loops can be helpful in the diagnosis and prognosis of certain lesions, and if we utilize narrowband imaging, these will show whether these vascular abnormal structures are benign, premalignant, or even malignant potential. These intraepithelial capillary loops form the basis for the Nye classification of the vascular changes of the vocal fold. Nye classified the vascular changes into 5 groups. The first 4 of them are benign groups. These are the first 4, the benign groups. Type 1 is when you have a thin and sometimes oblique arborescent, this divide and branch vessels. They interconnect on the surface, but they don't have loops and they are thin. When they grow thicker, and you can see how they grow thicker by the narrowband imaging here, but still they don't form the intraepithelial loops, they are type 2. When these changes are obscured by the whitish epithelial lesion on top of the vocal fold, like keratosis or hyperplasia, and you cannot see the vessels clearly, where you cannot see intrapapillary capillary loops. This is type 3, when you can actually see the loops, but you only see them as dots on the surface, like in here, just dots on the surface, then it is type 4. These 4 types are fairly benign. The type 5 in the classification includes the premalignant or the malignant lesions of the vocal fold, divided into 3 parts, 5A, B, and C. In 5A, the loops are still well formed. They can form solid or hollow, brown, various shapes on the surface of the vocal fold. You can see them as solid shapes. When it becomes a B, some destruction to these loops had happened by the tumor process. So you no longer see the solid shape, you only see line shape that can take the form of little worms or little snakes, some small vessels on the surface like a line. And type C, the tumor necrosis would cover most of the loops, so you only see scattered loops with various shapes, very irregular and very scanty on top of the tumor surface. And this is an example of the intraepithelial capillary loops in respiratory papillomatosis, where you could see the dot-like appearance of these loops. This is type 4, which is a benign tumor. And here are examples of premalignant lesions like carcinoma in situ or erythroplakia, which resembles type 5A. You could see the lesions on the vocal fold surface, and you could see the narrowband imaging of the loops, which show solid intrapapillary loops, fairly symmetrical in their distribution. These solid loops can be seen clearly because the epithelium is still fairly translucent, and you can see the deeper layers of the vocal fold, including these loops. In the so-called erythroplakia, which describes a reddish appearance as a premalignant lesion of the vocal fold, you are actually seeing these vascular loops. But in established vocal fold carcinoma, the type 5B or C lesions, the intrapapillary loops would already start to necrose by the tumor effect. So you only see the loops in the periphery of the tumor rather than in the center. Again, either like a very thread-like, worm-like, or small snakes in the periphery, or very irregular lines on the periphery, very scattered in type 5C. These are the results of the destruction of the loops with the vocal fold carcinoma and covering of the loops in the center of the tumor by the necrotic tissue. By this, we come to the end of this part 2 lecture on the rather uncommon vocal fold lesions. Assalamu alaikum.